Now joining us for the Ivy Rehab Injury Report. Ivy Rehab with over 18 locations with best-in-class physical therapy around South Jersey. Dr. Ashley Tress joins us as there's some interesting injury conversations they get into, and Ashley will kind of give us some insight about the how behind some of these situations could even be occurring, because I know for me, anytime anyone talks about an injury, it's like people come to me and they'll be like, well, did you have this injury? And it's like, yes or no. And if you did have the injury, you're like, well, I don't actually know. I'm not an expert on these things. So Ashley, we appreciate you jumping on today. How's it going?
It's good. I'm glad to be here. It's beautiful weather outside, just in time for all the spring sports, and baseball's kicking off. So ready to be back in the thrall of it.
Well, we appreciate you jumping on. We'll only keep you indoors for so long that you go out and enjoy it with everybody else. Let's start with Flyers forward Tyson Foerster, because a lot of people are shocked that a guy who people thought he was not going to come back this season. He was done. I mean, that upper body injury he sustained looked very serious back in December. Then he had surgery a week later. And then you see him come out. Of course, Flyer fans were losing their mind the other night because he got tripped up and almost flew into the board. He might have re-injured himself. He ended up being fine. So talk to the audience about what would go into someone who had surgery to come back a month or two earlier from an injury that would have to do with the shoulder and the bicep.
Yeah, definitely. So a lot of times it really depends on, one, the type of injury, and two, the type of surgery that was required in order to fix those typical types of tissues. We have obviously different types of tissues throughout the body: ligaments, muscles, bones, tendons. And each of those different types of tissues have different healing times. The biological healing times is really what drives the first half of these rehab processes. So, for example, a person who has like a rotator cuff tear, that's a lot of muscles. You have to reattach the muscles to the tendons, to the bones. Those tendons need at least 6 weeks to adhere to the bone in order to prevent recurrent injury, recurrent tear. So you want to shut those muscles down and not really use them for at least 6 weeks to allow for that biological healing time. And depending on other factors, any previous past medical history, any previous injuries, those types of things also play a huge role into that kind of recovery time. So based off, every surgery is a little bit different. Every surgeon's a little bit different. So protocols do kind of vary a little bit, but generally that first couple of weeks, it's really that we call that kind of phase one. It's really just to shut down the area, really control pain, really control inflammation, and just gentle kind of motion. Sometimes they're typically in a sling, but again, it depends on the type of surgery. It depends on the protocol. And that sometimes that can vary between 4 to 6 weeks. From there, we can kind of progress into some gentle passive motion. That's when your physical therapist can kind of move the arm or the limb through gentle range of motion. Again, just trying to prevent any kind of stiffness. Again, that can be between from that 4, 6 to 12 weeks, depending on the type of surgery. From there, once you kind of hit that 8 to 12, 10-week kind of range, that's when we can start some gentle strengthening. That allows any of those ligaments, muscles, tendons that allow that biological healing time to have those healing properties, give it time to rest and relax and be prepared for what's to come. We gradually progress the strengthening. We don't want to do too much, too fast, too soon. That's how we progress and make injuries and surgeries worse. A lot of tendinitises and tendinopathies tend to come from that too fast, too soon, too much kind of overload. And we really want to prevent that. So, sometimes it's a slow and steady wins the race kind of approach, but we do have to be very consistent with those healing times. Once we kind of get to that 16-week range. So now we're kind of talking about that 4-month range, if we're kind of putting in months time. That's when we can really start working on a little bit more of that sports specific. We can start driving into those higher level, more fun kind of activities, those plyometrics, for like some chest presses or some bounces, kind of getting back into that sport level type of rehab. And then from there, around that 24-week kind of, or that 20, that kind of area, once we get into that phase 5, that's when we get to back to that return, that really heavy return to sport phase. Generally, those can depend based off of the sport. Obviously, we were going to rehab somebody with a baseball shoulder injury different than a hockey player injury. Those are two very different sports, very different mechanics, very even different psychological mindsets of what you have to kind of get back to. So addressing those psychological factors throughout the entire rehab process is also a huge goal and aspect to recovery as well. Generally, those kind of return to sports starts with those performance kind of like, hey, let's just start getting used to those motions again. Once the team and the team doctor, the team therapist decide that, okay, that's all looking good, and they clear them for to return to their practice kind of programs. Generally, those start off with those kind of non-contact drills, just light, skating, just holding the stick, those types of activities. Then they can progress into a contact type of drill, more physical practices. And then once they're deemed that it's safe and everything's okay, that's when they're kind of returned to play. So there's a lot of different aspects that kind of go into this kind of return to play as far as timeline is concerned, depending on, and we've seen it in, concussion protocols across different sports as well, how quickly people progress through those concussion protocols. People can kind of progress through those contact drills, non-contact return to play kind of protocols as well. It's not we like to see it being linear, but sometimes we do have it, kind of fluctuate a little bit.
All right, so let's backtrack a little bit, because let's say someone comes into IV rehab, right? Let's say somebody, had a shoulder or an arm procedure, right? And they are progressing well. So like, give an example of like, what is a checkpoint? What is hey, they can do this, and this is an obvious example of why you can maybe take that step from the light work to the more heavier work, or from the heavier work to the more explosive work? Like, what are like the kind of checkpoints that IV rehab would check with somebody if they walked in and they were working with them for a few months?
Yeah, definitely. So other than kind of abiding by those biological healing times, we also look for like muscle and joint kind of compensation. So a lot of times we see with any kind of like rotator cuff pathology, or really a lot of shoulder pathologies in general, people tend to really want to hike that shoulder because those muscles are not working as properly as they should. The rhythm isn't where it should possibly be. There's a certain ratio we like to see as far as shoulder blade movement compared to arm movement. So that's where a lot of times you see a lot of people trying to reach, and they're kind of shrugging up their shoulder that way. So really trying to focus and hone in on a lot of those very tiny, minute, specific biomechanics to make sure that those muscles are firing appropriately. We're not getting any of those compensations. So, we can see somebody raising their arm. Oh, look, that's moving great. We don't see that compensation. Now let's add a little bit of weight. And now you give them a 1 pound, little pink 1 pound dumbbell, and they're like, oh my gosh, I can't lift this. They're like, oh, but I can lift my arm. But then you're starting to see that compensation. So then we try to start being creative and say, okay, well, you can get to maybe this point before you start hiking. Let's shorten that range, or let's bring you up to a certain point and then continue to progress there. So there's a lot of individual specific care to say, oh, what are you able to do? What's our goal? And then it's kind of a teamwork as to say, what can I do to make that person get to their goals within our knowledge and biomechanics?
Let's get to another point, because you mentioned baseball earlier. This situation, I think, is absolutely wild. It's a non-Philly sports team, but I think it's an injury that, I know for me, and I've been covering sports for a long time, I was like, wait, what? So for those who haven't heard, Jose Berrios, who's pitched in the league for over a decade, he has a right elbow stress fracture, but he will not need surgery. He's in the middle of his throwing program, and they're hoping to rebuild his arm back up, because apparently you can have a stress fracture in your elbow and you can still pitch. Like, how on earth is that even possible? Because, when people hear stress fracture, they think, gotta shut the guy down. But the Blue Jays are saying, no, it's not bad enough to shut you down completely. You just don't need surgery. We can rehab you back. So, what is a stress fracture in the elbow, and what does that mean for someone recovering?
So generally what happens with a stress fracture is that it's a lot more of an overuse type of injury. Very different than say like a tendonitis or a tendinopathy. So those like I mentioned before, the muscles are tendons and they attach to bone. And bone is actually living tissue. A lot of people don't really kind of think about that. So when you use a muscle and the muscle pulls on the bone has to kind of break down and then reform in order to make it stronger, in order to support all of that extra load. I mean, these guys are pitching, 90 average, 90, 100 miles an hour for seven at minimum 70 pitches, a game. That's a lot of force going through these types of structures. And, if you don't have the proximal support, if your rotator cuff, your proximal shoulder muscles aren't strong enough to generate that kind of thing, or the lower wrist muscles are doing something a little bit different, depending on the type of pitch you're trying to throw, that's ending up having a lot of torque and a lot of force on that inside part of the elbow. Especially with baseball, you see a lot of those UCLs, those Tommy John type of injuries, but that's looking really more specific at those ligaments that attach bone to bone. So what happens here with the stress fracture is the muscle is pulling on the bone, and the bone's not necessarily strong enough to withstand all those types of forces. So, generally what we try to do initially when you have those types of stress fractures, we do initially try to shut everything down. Depending on, the pain level, a lot of times the pain level really kind of drives some of these rehab processes also. So if he's like, yeah, it's bothersome, it's a little achy, but I ice it and I can kind of get through it, then that could be a component to say, all right, low pain levels, less than a 3 out of 10. Let's try to increase it a little bit more. So we may have to shut it down for a day or two. And then, we can start gradually reloading those tendons and the tendons, the muscles, the bones in order to get back to where he needs to be. I would definitely be a little optimally cautious. It is the beginning of the season, so we don't want to do too much too soon, too fast, and just kind of keep it in the back of our minds.
I want to point out the part about how sometimes the pain can dictate the recovery, because I know I went through that with myself where, for my rehab, Ivy Rehab Physical Therapy, for me, it was a part of my neck was still not recovered, but it wasn't the part of the neck that was the main source of the injury. So, for me, that was like something I had to have a conversation with about, hey, this is still bothering me. What can we do about it? And that dictated the rehab moving forward. So I think it's an important thing to point out to people that, when they come to Ivy Rehab Physical Therapy, you guys are going to be like, hey, talk to me about what the pain is. Talk about what you're feeling, because if we know what you're feeling, we can better address it.
Yeah, definitely. And it's such a huge component. And I spend a lot of time with my patients on all of this kind of education component. A lot of people come to me, they're like, I have no idea why my shoulder hurts. And I'm like, well, you have some tendonitis, it's your rotator cuff. They're like, yeah, but it hurts here. And I'm like, and I just have to explain that that's a very common referral pattern. A lot of our muscles have specific motor patterns and referral patterns to tell us kind of and give us an idea as to where, the kind of pain is. Also, the kind of pain also tells us a little bit more, whether it's a burning kind of pain or is it a sharp shooting kind of pain? Is it numbness, tingling? If I have somebody saying, oh, I have shoulder pain, and it hurts my shoulder when I turn my head to the right, well, maybe we want to look up to the neck a little bit more, because it's very common that, those nerves are being pinched coming from the neck. Maybe we have some disc issues or some other joint mobility deficits that we have to address. And it's difficult for people to understand. They're like, well, my shoulder hurts, but the really driving factor is coming from the neck, or it's coming from a different area of the body. So a lot of that education component is so super important. And I think that kind of goes across any field of physical therapy, whether it's community based like what we do, or if it's definitely even at the higher levels with all the sports.
And again, Ivy Rehab Physical Therapy with over 18 locations around South Jersey. First in class physical therapy. They're my physical therapists, and they should be yours as well. And Dr. Ashley Tress joined us here on Hanging with Hennig on 97.3 ESPN. Ashley, really appreciate you jumping on. Great stuff today. Kind of explain to the audience some of the how and the why for some of these athletes.
Yeah, definitely. It was fun to be on.
Appreciate you jumping on. We'll talk soon.
All right. Thank you.